Let's go over the warm-up review. First question, what effect will stimulating each of the following receptors have on heart rate? So stimulating beta 1 will increase heart rate. Stimulating beta 2 will also increase the heart rate, kind of indirectly, because beta 2 stimulation causes vasodilation, which lowers the blood pressure, so the heart rate rises to compensate. And then stimulating M2 receptors will decrease the heart rate. Next, what are the primary mechanisms of action of the different classes of antiarrhythmics? So the mnemonic is no bad boy keeps clean. So class 1 is sodium channel blockers, class 2 is beta blockers, class 3 is potassium channel blockers, and class 4 is calcium channel blockers. And the last question, a patient comes to the clinic complaining of anterior shoulder pain that radiates down the forearm. On examination, there's swelling of the biceps muscle. So what's the most likely diagnosis? Biceps tendon rupture. Now we're ready for the lecture.
Welcome to another Step 1 video. I'm Dr. T. In this lecture, we'll continue talking about some of the complications we encounter in pregnancy, and then we'll finish by discussing some of the medications we use during pregnancy. Let's start with abnormal placentation. Last time we talked about how the placenta develops.
Well, what's going on?
Hey, what are you doing here? I thought you were off today.
Nope.
Oh.
Look, we've talked about this before. You can't be my stand-in, okay?
I know.
So, may I take it from here?
Okay.
So, normally the placenta is located up here near the fundus of the uterus, well away from the cervical os. However, sometimes the placenta implants down here in the lower uterine segment. And if it covers the internal cervical os, it's called a placenta previa. Placenta previa is when the placenta overlies the cervical os. Risk factors for this include increasing maternal age and multiparity, so increasing number of pregnancies. But the big risk factor to know is a history of a C-section. And this is because it's thought that scarring from the C-section keeps the placenta from implanting in a normal location. As the pregnancy progresses, changes in the cervix and the lower uterine segment will cause the placenta to detach in small spots. So these patients present with painless vaginal bleeding, usually in the second half of pregnancy. And then you would get an ultrasound to make the diagnosis. One important point that you have to get the ultrasound before you do a digital exam, because if you accidentally stick your finger through a placenta previa, you'll cause a massive hemorrhage. The treatment for a bleeding previa is a C-section. Both placenta previa and a history of a C-section are risk factors for 3 other types of abnormal placentation: placenta accreta, placenta increta, and placenta percreta. Placenta accreta is when the placenta is abnormally adhered to the myometrium. Placenta increta is when the placenta invades into the myometrium. And placenta percreta is when the placenta invades through the myometrium and serosa. So placenta percreta penetrates through the uterus. Percretas can even invade surrounding structures like the bowel, bladder, or large pelvic vessels like the iliac arteries. So accreta adheres, increta invades, and percreta penetrates. Like I said, these are associated with previas and with prior C-sections. Again, it's thought that the scarring from the C-section prevents normal development of the placenta. These can be diagnosed on ultrasound, and oftentimes MRIs are also used in an attempt to pinpoint the degree of placental invasion. But sometimes they're not found until after delivery, when you try to deliver the placenta and it won't detach. These can cause massive, life-threatening hemorrhage as well. So the treatment is usually C-section followed by hysterectomy. Let's move on to placental abruption, which you may also see referred to as abruptio placentae. This is a premature separation of the placenta from the uterus before delivery. This is bad because then the fetus is deprived of oxygen and the mom can lose a lot of blood. The moms can also develop DIC, so this is a very serious complication, both for the mom and the baby. Risk factors for placental abruption include history of a prior abruption, hypertension, including pregnancy-induced hypertension, trauma like a car accident, smoking, and cocaine use. Test writers especially like to use cocaine use as a clue for placental abruption, so remember that one. Placental abruption presents as sudden onset, painful vaginal bleeding in the second half of pregnancy. So we said placenta previa causes painless bleeding late in pregnancy, while placental abruption causes painful bleeding. And this is associated with contractions and evidence of fetal distress on the fetal heart rate monitor. The treatment for placental abruption is an emergency C-section. We've talked about some of the causes of bleeding late in pregnancy, like placenta previa and placental abruption. What about bleeding after delivery? This is called postpartum hemorrhage. You usually encounter it right after delivery, within minutes, but sometimes you can have delayed postpartum hemorrhage, occurring in the first couple of days postpartum. So what are some of the causes of postpartum hemorrhage? This is number 4 in your study guide. The most common is uterine atony. After the placenta detaches, the ends of the spiral arteries in the uterus are still open and bleeding. And what stops that bleeding is the myometrium contracting down to constrict those vessels. So if the uterus doesn't contract, if it's atonic, then the spiral arteries remain open and you get a lot of bleeding. They'll describe this on your test as an enlarged, soft, boggy uterus. And the risk factors include an overdistended uterus, like with a large fetus or with a multifetal gestation, induced or augmented labor, or prolonged labor. You can think of it as the uterus being overworked and then too tired to contract effectively to stop the bleeding. Retained placental tissue is a cause of postpartum hemorrhage. The retained tissue prevents the myometrium from contracting down. Genital lacerations are a common cause. We mentioned that placenta accreta, increta, and percreta can present as excessive bleeding at delivery. And uterine rupture is a rare but potentially very serious cause. Let's switch gears and talk about hypertension in pregnancy. Hypertension is a common problem in pregnancy, and there are a few different types, so let's go through them. Chronic hypertension is the term used to describe someone who has hypertension already before pregnancy. So a patient who has a history of hypertension, maybe she's already on antihypertensives, and then she becomes pregnant. Do you remember which common antihypertensive is a teratogen? ACE inhibitors, and you worry about renal abnormalities with those. 5 antihypertensives that we do use during pregnancy are methyldopa, labetalol, amlodipine, as well as nifedipine and hydralazine. Methyldopa is a central-acting alpha-2 receptor agonist. Labetalol is a combined alpha-beta adrenergic blocker, and amlodipine is a calcium channel blocker. Gestational hypertension is hypertension that arises during pregnancy and then resolves postpartum. So this is a new onset hypertension greater than 140/90 after 20 weeks of gestation. And this is not associated with proteinuria. Generally, we do not treat gestational hypertension with antihypertensives because it hasn't been shown to improve outcomes. So the management is basically close monitoring to catch any progression of the disease. Preeclampsia is gestational hypertension plus either proteinuria or end organ dysfunction. We don't know exactly why preeclampsia occurs, but one theory is that there's abnormal development of the placental blood vessels, leading to placental ischemia and an inflammatory response. Another theory is that the mom's immune system reacts to paternally derived antigens in the placenta. In any case, what happens is widespread endothelial dysfunction, leaky vessels, and vasospasm, leading to hypertension, proteinuria, and possibly damage to other organs. Risk factors include a history of preeclampsia, extremes of age, so women less than 18 and women older than 40, nulliparity, so women in their first pregnancies, chronic hypertension, diabetes, multifetal gestations, and hydatiform moles. So, preeclampsia is diagnosed if someone has new onset hypertension greater than 140/90 after 20 weeks gestation, as well as proteinuria. And that proteinuria has to be at least 300 milligrams in 24 hours. If there is no proteinuria, you can still make the diagnosis if there's evidence of end organ dysfunction like thrombocytopenia, renal insufficiency, elevated LFTs, pulmonary edema, or cerebral symptoms like headache, visual disturbances, and seizure. Preeclampsia is considered severe when there's evidence of end organ dysfunction, all those things I just mentioned, or if the blood pressure is greater than 160/110. Then there's a variant of severe preeclampsia known as HELP syndrome. HELP stands for hemolysis, elevated liver enzymes, and low platelets. And finally, eclampsia is when someone with preeclampsia has a seizure. This is due to CNS involvement. The anticonvulsant of choice for this is magnesium sulfate. So this is different from other seizures. With eclampsia, use magnesium sulfate to terminate the seizure. The management is generally the same for severe preeclampsia, HELP syndrome, and eclampsia. We give rapid-acting antihypertensives like hydralazine, labetalol, or nifedipine to bring the blood pressure down if it's greatly elevated, over 160/110. This is to prevent the patient from having a stroke. We also give magnesium sulfate to prevent seizures or to terminate a seizure in eclampsia. And then the definitive treatment is delivery. And this doesn't necessarily have to be a C-section. You can also induce labor. We'll talk about some of the medications we use for this later in the lecture. But keep in mind that it takes a few days for the dangers of severe preeclampsia to resolve. In fact, the highest chance a woman has for developing an eclamptic seizure is in the first 24 hours after delivery. Similar to how you can have pregnancy-induced hypertension, you can also have pregnancy-induced diabetes, and we call that gestational diabetes. This is number 5 in your study guide. During pregnancy, the placenta secretes a hormone called human placental lactogen, or HPL. One of the functions of HPL is to decrease insulin sensitivity in the mother so that she doesn't utilize as much glucose, and instead the glucose is available for the fetus to use for nutrition and growth. But sometimes this response is exaggerated, leading to gestational diabetes. So gestational diabetes is diabetes that arises during pregnancy but then resolves postpartum. We screen for this in everyone using an oral glucose tolerance test between 24 and 28 weeks of gestation. And then the management is with a diabetic diet plus or minus insulin if better control is needed. The main complication we worry about with gestational diabetes is fetal macrosomia, or big babies. These infants are at risk for labor complications such as a shoulder dystocia during delivery, and they can also become hypoglycemic after delivery. And why is that? During pregnancy, if they're exposed to too much glucose, the fetal beta cells in the pancreas will undergo hyperplasia to produce more insulin. And then once you take away all that glucose after delivery, the infants can become hypoglycemic. Now, what about those people who are already diabetic, either type 1 or type 2 diabetic, and then become pregnant? We call that pregestational or overt diabetes. We manage this with insulin to get really tight glucose control. While we worry about macrosomia and post-delivery hypoglycemia here as well, infants of these mothers can have even more serious complications, including congenital abnormalities like cardiac defects or caudal regression syndrome, which is a sacral dysgenesis. The lower part of the body doesn't form properly. There is also an increased risk for unexplained stillbirths, so these patients are usually delivered a little earlier. I want to finish by talking about a few of the medications we use during pregnancy, starting with terbutaline. Terbutaline is an asthma medication that's also sometimes used as a tocolytic, a medication to delay preterm labor. Terbutaline is a selective beta-2 agonist, so it causes bronchodilation in the lungs, making it useful for asthma. But beta-2 receptors are also found in the uterus, and activating them there leads to uterine relaxation. So if you can make the contraction stop, this delays labor. Usually this delay is only on the order of hours to a couple of days, so this isn't a cure for preterm labor. It's basically just gives you some time so that you can give the mother glucocorticoids to promote fetal lung maturity. Some of the side effects of terbutaline include tachycardia, hypotension, and pulmonary edema. Step Up also mentions ritodrine, which is another selective beta-2 agonist. Ritodrine is also approved for preterm labor, but it's not available in the US. Another class of drugs we use quite often in obstetrics is the prostaglandin drugs. Generally, these cause cervical dilation and uterine contractions, so we use these early in pregnancy to terminate the pregnancy, or late in pregnancy to induce labor. There are a bunch of different ones available, but I think the two you should know are misoprostol and dinoprostone. Dinoprostone is a prostaglandin E2 analog, and misoprostol is a prostaglandin E1 analog. Misoprostol is also used to prevent peptic ulcers in people taking NSAIDs, and it can also be used to keep patent ductus arteriosus open. For both dinoprostone and misoprostol, you worry about uterine hyperstimulation or excessive contractions, which can cause fetal distress and even uterine rupture. In fact, if during labor induction the administration of misoprostol causes inadvertent uterine hyperstimulation leading to fetal distress, a medication now familiar to you, terbutaline, can be used to acutely stop the hyperstimulation and relieve the stress on the baby. The next drug is mifepristone, also known as RU486. Mifepristone is a competitive antagonist at the progesterone receptor, so it's an anti-progestin. Now remember, we said that progesterone is progestational. It's necessary for maintaining a pregnancy. So if you give mifepristone, an anti-progesterone, early in pregnancy, that causes the blastocyst to detach and the myometrium to contract, ending the pregnancy. So that's what mifepristone is used for, the medical termination of early pregnancy. And you usually give mifepristone along with misoprostol. The misoprostol increases the uterine contractions to ensure that the detached blastocyst is expulsed. Side effects of this regimen include vaginal bleeding, abdominal pain, and cramping, nausea, vomiting, and diarrhea. Okay, that's it for this lecture. Now it's time for the end of session quiz. Which placental abnormality matches each of the following descriptions? Placenta covers internal cervical os. Placenta previa. Premature separation of placenta. Placental abruption, abruptio placentae. Abnormal adherence of placenta to myometrium. Placenta accreta. Invasion of placenta into myometrium. Placenta increta. Invasion of placenta through myometrium and serosa. Placenta percreta. Presents as painless vaginal bleeding late in pregnancy. Placenta previa. Presents as painful vaginal bleeding late in pregnancy. Placental abruption. Next, what is the most common cause of postpartum hemorrhage? Uterine atony. Next, what condition is best described by each of the following statements? Patient with past medical history of hypertension becomes pregnant. Chronic hypertension. New onset hypertension during pregnancy with no proteinuria. Gestational hypertension. New onset hypertension during pregnancy plus proteinuria or end organ dysfunction. Preeclampsia. Patient with preeclampsia has a seizure. Eclampsia. Patient with preeclampsia has low haptoglobin, low platelet count, and high AST. HELP syndrome, hemolysis, elevated liver enzymes, and low platelets. Next, what is the mechanism of action of mifepristone? What is the mechanism of action of terbutaline? Mifepristone, or RU486, is a competitive inhibitor at the progesterone receptor, so it's an anti-progestin, and it's used to terminate early pregnancies. Terbutaline is a beta-2 agonist, so it causes uterine relaxation, and it's used to delay preterm labor. That's it for this video.
Ooh. Can I at least do the outro?
Sure.
Oh, yeah. That's it for this video. Good luck on your exam, and don't forget to vote for me, Dr. T, and my beard using the hashtag DITbeard.
Hello boys and girls, I'm Dr. Lewis, and welcome to Lou's Clues, the show where we learn about medical stuff. Let's get started! Yay! Today our special guest is my daughter Rebecca. Say hi, Rebecca.
Hi.
Great, let's get started. Now Rebecca, do you know where babies come from? It's not from a stork.
Dad, everyone knows that. Babies come from mommy's tummies.
Well, it might be more complicated than you think. Do you have any questions about how babies grow?
Not really.
Really? Nothing? Nothing at all?
Oh, okay. What's a placenta?
Wow. Rebecca, if I had a nickel every time a 7-year-old asked me about placentas, I'd be a rich man. But let me answer your question. The placenta is an organ that connects the developing baby to the uterine wall to allow nutrient uptake, waste elimination, and gas exchange via the mother's blood supply.
Yeah, I already knew that.
Really?
Uh-huh. What about placenta previa?
What are they teaching you in first grade? Well, the placenta previa is where the placenta covers the internal cervical os, but...
Oh yeah, that's only diagnosed in the 3rd trimester. Now I remember.
What? Where is this coming from? Okay, if you're so smart, how do you cure placenta previa?
Trick question, Dad. Everyone knows you need a C-section with a placenta previa.